Hi there. My name is Kate Wilcox. I'm a third year internal medicine and pediatrics resident at Medical College of Wisconsin. I'm a proud cardio nerd. I'm here recording with them today. We're a fellow founded online digital medical education platform, and our mission is to democratize cardiovascular education. I'm really excited to be here today with Dr. Preiss, talking about some late breaking research for the AHA. Dr. Preiss is an associate professor with the Medical Research Council Population Health Research Unit in Oxford. His focus is in preventative cardiology with a particular interest in glycemic and lipid modification, and we are so excited to be talking with him today about EMPA-Kidney. Thank you so much for joining us, Dr. Preiss.
I very much appreciate the invitation and look forward to discussing the trial and other results with you.
Do you want to give us just a little bit of background on EMPA-Kidney before we get started?
Yeah, sure. So the EMPA-Kidney trial was probably, we came up with a design back in kind of 2017, 18. And there was emerging data at that point suggesting that this class of drugs, the SGLT2 inhibitors, may well be protective for kidney disease. And of course, now there's a plethora of studies showing some benefit across a range of disease. But we wanted to design a trial which was very large and also included groups of patients who maybe hadn't been adequately covered or weren't being adequately covered in other studies that were up and running at that point or in the design stage as well. And so we designed a trial which turned into EMPA-Kidney, working closely with a commercial partner. And this trial ultimately recruited 6,609 patients, all with chronic kidney disease, and recruited them across 8 countries in different parts of the world, which we could go into. And I think some of the important features of the trial were in particular to recruit patients with lower levels of eGFR, or worse levels of renal function than had been aimed at other trials that were being designed or conducted. And secondly, and perhaps most importantly, to also ensure that we had a large number of patients in the trial without diabetes. Because of course now we've seen benefits for these drugs across a range of patients, both with and without diabetes, especially in heart failure. But at that point, the big question was, are these results we're seeing in patients with diabetes really real? Are they as good as we see? And in particular, do we also see these kind of benefits in patients without diabetes? So the trial was set up to be large enough to address all these questions.
Thank you, Dr. Preiss. That's super helpful on that background there. Like you alluded to, SGLT2 inhibitors have been really unexpected and practice changing in research and clinical practice over the last couple of years. What specific question were you trying to answer with this trial?
So there was emerging data at this point, both from multiple programs of different drugs, but it was in particular a publication from the EMPA-Reg trial. So the EMPA-Reg trial was a study comparing empagliflozin to placebo in patients with type 2 diabetes who either had cardiovascular disease or at very high risk. And some of those results were quite surprising when they came out. I mean, the drug was shown to reduce cardiovascular death, which was a surprise to everybody at that point. And then there was a second paper in the New England Journal of Medicine led by Christoph Wanner from Würzburg in Germany, who's a close collaborator of ours. And this paper showed really quite remarkable reductions in the development of renal complications and deteriorating renal disease in patients in the study. Now, these patients weren't recruited because they had chronic kidney disease. Most of them did not. But it looked very compelling to study this potential reduction in cardiovascular and renal complications in patients with renal disease. In addition to that, I think we also have to give credit to people who ran the Credence trial of a similar drug, canagliflozin, because they really started their trial all in patients with diabetes and chronic kidney disease, but started it at an early stage. And I think we need to give credit to those investigators for setting up such a good trial so early on, so that we already had good data for the benefits of these drugs in patients with diabetes. But anyway, we had a lot of background information, and obviously during the conduct of EMPA-Kidney, this has just multiplied. But it was really trying to answer this question both in patients with and importantly without diabetes to see if we could improve the outcomes. I'm not a nephrologist, but my kidney disease colleagues tell me that really the last big development in kidney disease management goes back to the days of the ACE inhibitors and the angiotensin receptor blockers. And really, there's been quite a big gap waiting for some other drug to come through and really meaningfully change outcomes for these patients. And I think EMPA-Kidney is now one of the trials that allows us to do that, which is excellent news.
It is excellent news. That makes a lot of sense. Thank you for going through that. It's fun to hear about kind of how the other trials led up to what you studied here. So you mentioned, one of the biggest differences in this trial is that you excluded folks with diabetes and that you had more folks with lower GFRs enrolled. Were there any other big differences from the previous trials as far as eligibility criteria?
Yeah, in terms of eligibility, first I should clarify, we absolutely did include people with diabetes and without diabetes. So the intention was not only to include people with diabetes, but to ensure that we had more than enough patients in each category so that we could potentially see if we could get benefits of a similar magnitude in patients without diabetes. And if you look at other trials in chronic kidney disease, there's been, EMPA-Kidney is the 4th trial conducted in patients with chronic kidney disease of these drugs. 2 of the trials only enrolled patients with diabetes. The 3rd trial is very important, the DAPA-CKD trial, and that showed really early evidence that these drugs may be very helpful in reducing renal disease progression in patients on Empagliflozin versus placebo. But that trial was still dominated by patients with diabetes. I think about 1,400 of the patients did not have diabetes. And so they actually had pretty few outcomes in patients without diabetes, even though the data looked pretty promising. And so EMPA-Kidney more than triples the amount of evidence we have in patients without diabetes on this class of drugs. So that's one notable thing to comment on. Another is, yes, we went to lower levels of eGFR. So many trials had cutoffs of eGFR of 30 or 25. In EMPA-Kidney, we lowered that down to a level of 20. And indeed, the way that eligibility works and the way that samples are taken, we actually have a reasonable number, even with an eGFR below 20 in the trial, for which interesting data will emerge. And so I think one of the other main values of the trial is extending our knowledge to what kind of lower levels are safe and efficacious to use these drugs. If I can add one more thing to your question about how is this trial a bit different, I'll give it a little bit of a, let's say, non-scientific angle, because many of the trials you see, and I would say all classes of agents, many big trials are conducted by industry, conducted in a very commercial way, often run in 30 countries or 40 countries around the world with hundreds, if not thousands of sites. Now, that's fine if you have the money to run a trial like that. Our perspective on how to run trials is a little bit different. We focus on having relatively modest numbers of countries. The fewer, the better. It's very complicated to set up a trial in a country. So the fewer countries you can conduct it in, the better. That also means that you have fewer sites, that they have more patients enrolled. And therefore, when the site is really busy running the trial, they know exactly what it's all about. You know, they're busy, they're living and breathing it. And so you get high quality data. So our view is to try and make very streamlined, relatively few sites, but big sites. And I think you'll see that with the 8 countries that took part. And indeed, most of the countries we worked with in the trial were run through an academic collaboration. Almost all of them were led by an academic group in a university who then worked with sites within their country, which I think is a slightly different model, but I think a model that I think is worth emphasizing for a second, because it is a little bit different to what you see in many of the mega trials that are reported these days.
Yeah, absolutely. That's really interesting. Thanks for giving us kind of the rundown. Was there something specific that you were looking for when you were enrolling the academic sites in the different countries? I think this was across 8 different countries you mentioned.
Yeah, good question. So it's always complicated, isn't it, when you set up a study? But prior to my involvement in Oxford, colleagues here had run a trial called the SHARP trial. So the SHARP trial goes back a few years now. It was run by Colin Bajent and Martin Landray, who are now chairs of this EMPA-Kidney steering committee, but they ran a trial of cholesterol lowering in patients with kidney disease, and that showed benefit of lowering LDL cholesterol. And I think one of the trials in kidney disease to show benefit on cardiovascular outcomes a few years ago now. But that trial also set up a network effectively of countries and collaborators who have remained long-standing collaborators around the world. I could give you different examples, but one of the early countries to contribute in the EMPA-Kidney trial was Malaysia. They were, I believe, incredibly good to have on board in the SHARP trial, and they came on board in EMPA-Kidney early on and recruited incredibly quickly and incredibly well, as just one example of how having contacts through a previous trial which was successful has allowed us to keep that collaboration in place and build on it with this new trial.
That's wonderful. That's amazing to hear about. Thank you. Okay, so thanks for telling us a little bit just about the background and setup of the trial. I was wondering if maybe you wanted to just go over a little bit about the baseline demographics of the study population that we ended up with from these 8 different countries.
Yes, absolutely. So overall, we randomized 6,609 patients. What I should say is that before patients were randomized in the trial, they went through a run-in phase. So what that means is patients were not immediately randomized if they were eligible. They first had placebo to take for a few months. And we do that in pretty much all our trials to try and allow people who have initial enthusiasm but ultimately are not that keen on joining the trial. And, you know, if you'd randomize them and then they'd fallen out, would have been harmful. So we have a run-in phase of a few months and then patients are randomized. So overall, 6,609 randomized across the 8 countries. Mean age was around 64. A third of participants were women. A quarter of patients approximately had cardiovascular disease. The mean EGFR in the trial is worth commenting on. At 37, it's low, obviously, because of the nature of patients recruited, but it's substantially lower than achieved in previous trials of these drugs. And finally, most importantly, perhaps, the number of patients who did not have diabetes in the trial was well over a half. So 54% of patients in EMPA-Kidney did not have diabetes and the remainder did.
That's amazing. That's really interesting about the run-in phase. Do you know off the top of your head, I'm just curious how many people dropped out in the run-in phase before you had the 6,600 that were randomized?
Fairly modest numbers. It's not a large percentage. But even though the purpose of the run-in remains incredibly important and valuable, it's a relatively modest percentage. But if one considers that if those patients had been randomized straight away and had fallen out of the trial early on or stopped taking the drug or whatever, you're immediately diluting your ability to show any benefit of the treatment. So even though it was a fairly modest percentage, overall it still helps the trial to maximize its statistical power to show benefit.
No, that makes a lot of sense. I just hadn't heard of that before. So that's super interesting and a great idea, whoever thought of that. Okay, great. So we kind of went over some of the baseline demographics. I think this would probably be a good time to just get into talking about some of the outcomes and kind of how you landed on the, the progression of kidney disease, GFR cutoff, which I noticed was different than other trials in the past. We can kind of go through all of that.
So in terms of the key outcomes of the trial had many pre-specified outcomes, but I think, important here to focus on the key ones. The primary outcome of the trial was a composite of 2 things, either cardiovascular death or kidney disease progression. Now, kidney disease progression itself was split up into different things. One component of that could have been a biochemical change. So if patients had a sustained drop in their EGFR of 40% or more, then that counted as an outcome. If their EGFR dropped to below 10, so really low levels, and that was sustained, that counted as an outcome. And also if patients either died from kidney disease or had end-stage kidney disease, all of those things counted towards the kidney disease progression, which, as I said, counted along with cardiovascular deaths as the primary outcome. Then in terms of key secondary outcomes, we also had 3 of those. The first is, I guess, what I would look at as a kind of a health economic outcome, which was all-cause hospitalization. So being hospitalized for any reason, whatever it is. And we could talk later, but that kind of analysis was done as a total events analysis. So it wasn't just counting the first time somebody was hospitalized, but it was counting every time anybody was hospitalized. The second outcome of importance was all-cause death, so dying from any cause. And the third is cardiovascular death or heart failure hospitalization. And that outcome was chosen really because we've seen good evidence from other studies that these drugs are likely to reduce that outcome, certainly in patients with heart failure, and indeed in the original EMPA-Reg trial. So that primary outcome I mentioned, and those three key secondary outcomes were really what we were looking for in the trial.
Interesting. That's super interesting. So the total outcomes, does that weight all of the hospitalizations the same, or does it matter like what's the first, what's the second, et cetera?
Well, what you tend to see actually, and I'll jump ahead a little bit, I won't tell you the results just yet for that, but it doesn't quite give them equal weighting, no. What you actually see is that it keeps the confidence intervals, if you analyze the first event, like our first events analysis, which is what most people use for most outcomes, or total events, actually doesn't change very much. We think it provides more reliable information, but it's really when you come to patients with, for example, heart failure, where they are being hospitalized multiple times with heart failure, hospitalization, complications, that's when it can make a particular difference to the statistical power. Actually, when we looked at it, when we do total events analysis for the outcomes in the EMPA-Kidney trial, it actually ended up providing pretty similar statistical power to what you see is if you do a first events analysis. And in my AHA talk, we do, for example, show some what we call total events analyses for some of the cardiovascular outcomes, and also first events analyses. And actually, you get pretty similar results, at least in this chronic kidney disease population, with whichever way you analyze the data. But the thing we pre-specified, most importantly for total hospitalization, for all-cause hospitalization, was that we would look at all events. So most importantly, you set up the rules at the start of your trial, and then you follow them later on. And that was the one outcome out of these important outcomes where we decided to look at all events and not just at the first one.
Interesting. That's really fascinating. Thank you for going through that with me. Do you want to go ahead and just kind of talk about the primary outcome and what the results were there?
Yeah. So the primary outcome was presented by my colleague, Will Harrington, who was the chief investigator for the trial. And just keeping in mind, that was a composite of either cardiovascular death or kidney disease progression. And what we found was that treatment with empagliflozin compared to placebo reduced that outcome by 28%. And we won't dwell on p-values or confidence intervals, but it was highly statistically significant, really no question of this benefit. What I should also go on to add then, because I think we've already talked about the importance of including patients without diabetes, is that when we looked at that primary outcome split into patients who did or did not have diabetes at baseline in the trial, then there was no obvious evidence of a difference in the proportional effect. So we concluded that the benefit was there in both groups, whether you had diabetes or not, which I think was incredibly important for the purposes of the trial and probably the standout result. One other thing I'll mention just about the primary outcome, which is covered in the AHA presentation, we also looked, because it's relevant to a cardiovascular audience, we looked at, is the benefit we observed any different between patients who had or did not have cardiovascular disease at baseline? Now, they all have chronic kidney disease, but presence or absence of cardiovascular disease, and the results are identical in proportional terms. So really, you could tell that this drug is beneficial overall. It's beneficial in patients with and without diabetes, and certainly beneficial in patients with and without cardiovascular disease with chronic kidney disease. I think if I then comment just on the secondary outcomes, because I think worth transitioning into what the data showed from the rest of the trial. I mentioned three key outcomes, secondary outcomes, all-cause death and either cardiovascular death or heart failure or hospitalization. Now, some trials of these drugs have actually shown a reduction in all-cause death. We did not show that. There was a reasonable number of deaths across the trial, but we did not show a statistically significant drop in all-cause mortality. And similarly, actually, when we looked at our primary outcome I've already talked about, which was cardiovascular death or renal disease progression, we actually had rather fewer cardiovascular deaths in the trial than we were anticipating. So I think we had about 118 cardiovascular deaths. And although the trend was in the expected direction, again, the trial just didn't have power to find a reduction in cardiovascular death. And therefore, when we looked at the wider composite of cardiovascular death or heart failure hospitalization, again, it very much trends in the expected direction, but the trial by itself did not show benefit for that outcome, although we would say, it wasn't powered on that basis. The trial was powered on the primary outcome. And so our interpretation is it's very much in keeping with all the other trials that have been done in this area. And then the final one, all-cause hospitalization, I think notably was reduced by 14%, keeping in mind that's hospitalization for any reason. And of interest to cardiovascular audience, again, it was consistent, highly consistent, whether you had cardiovascular disease at baseline or not. And I think that's important in this population because the rate of hospitalization was really high. These patients do get hospitalized frequently. So to put a number on that, if you look at patients on placebo, then if they had both chronic kidney disease and cardiovascular disease, almost half of them were hospitalized during the trial. So really high rate of hospitalization. Even those who didn't have cardiovascular disease were hospitalized. Well over a quarter of patients on placebo were hospitalized. This is only over 2 years. The trial ran for an average of 2 years. So a 14% reduction in that outcome, we believe, is notable and potentially of importance to patients and to health economic, aspects of the trial.
Yeah, absolutely. Those are really exciting results when we're talking about trying to save our health systems money and, as far as what makes sense for prescribing medications. Thank you for going through all of that. This is really exciting to talk with you about. One question that came up when I was listening to you, and when I was reading through it before, what exactly went into you guys determining the GFR cutoff for the primary endpoint?
Yes, so as a non-nephrologist, certainly my colleagues, have been involved in discussions where the renal community has tried to come up with drops in eGFR, which are considered to be clinically important. And so there are guidance documents and other trials which support the use of a 40% drop, as long as it's sustained. So by sustained, just having one value which had fallen by 40% and then bounced back up a bit did not count. You had to have it at 2 visits in a row. However, a good question that you ask, because other trials have used a 50% drop. So for example, the CKD trial used a 50% drop, not a 40% drop. And so one thing we have done in a linked meta-analysis, which will be published on the 6th of November, is to also analyze the EMPA-Kidney data using a 50% drop. And that allows us to combine it with the CKD trial and indeed with other trials. So colleagues of mine sought data from all these big trials, and they pooled data using a kind of common definition, because that is one of the troubles we've had is trials may have used slightly different definitions. But if you use a common definition, the reduction or the benefit in the EMPA-Kidney trial is at least as big, if not bigger, if you use a 50% reduction. And if you pool all of those trials together for this kidney disease progression, you get, really a phenomenal reduction in risk, which is consistent whether you have diabetes or not. So I would say 40% reduction has been pretty well supported in the renal community and highlighted in different guidance documents, but other trials have used other cutoffs. But, if we use a common cutoff, then you still get very compelling results, if not more so than for a 40% cutoff.
Absolutely. That's helpful to know. And I know this is such a beautiful example of cardiologists and nephrologists working closely together to have some shared data. Were there any other kind of results here that you wanted to talk about, maybe focusing on for cardiologists, what the major takeaways would be from this wonderful trial?
Well, I think as I noted, some of the key cardiovascular outcomes for this one trial were somewhat limited in the number of outcomes that accumulated. The follow-up was quite short, and the renal benefit was so substantial that perhaps we didn't have long enough to show a cardiovascular benefit in this one trial. So what we've done in addition to this is to combine the EMPA-Kidney trial results with all the other big trials, as I alluded to. So along with looking at renal progression results, we've also combined data for cardiovascular outcomes, such as cardiovascular death, and also the composite of cardiovascular death or heart failure hospitalization. And really what you see when you combine EMPA-Kidney with 12 other large trials is that, firstly, you have an amazing data set of over 90,000 participants. Significant proportion of them do not have diabetes, but what you see is very consistent reductions in these trials overall in cardiovascular death. So overall, there's a 14% reduction in cardiovascular death. And with all these trials pulled together, again, it doesn't really matter whether one has diabetes or no diabetes at baseline. I should really stress that these trials have been done in high-risk populations. So they've been done in patients either with type 2 diabetes, along with cardiovascular disease, or they've been done in participants with heart failure who may or may not have had diabetes. And as EMPA-Kidney's shown, we've also done trials in patients with chronic kidney disease with or without diabetes. So those three key populations, if you put them all together, 14% reduction in cardiovascular death. If you then look more widely at cardiovascular death or heart failure hospitalizations, then you get something like a 23% reduction. And again, highly consistent across these groups of patients, and does not matter whether patients had diabetes or no diabetes, the results still appear very consistent. So I would say from a cardiologist's perspective, there is hugely compelling data. I mean, we already had trials in the heart failure space which show that these drugs are incredibly effective in that group. And in our meta-analysis, we also plot that. We plot the absolute benefit of these drugs in heart failure, and the absolute benefit is astounding in heart failure, which is why these drugs are now becoming really foundational treatments used early in heart failure rather than waiting, until patients have tried multiple other drugs. Our hope is that the same thing will happen in patients with chronic kidney disease or who are at risk of progressing. Treatment options are somewhat limited at the moment. Some drugs are quite difficult to introduce, certainly with an ACE inhibitor, there's a lot of dose titration, there can be some issues. Those treatments remain fundamentally important. However, hopefully there will be a move towards introducing these SGLT2 inhibitor drugs in time, not just in patients with diabetes, but also those without diabetes. So I think the cardiologists will be aware of the substantial cardiovascular benefits, but I think also worth highlighting the kidney benefits that their patients would derive. Maybe one final thing, which we haven't touched on, but which occurs to me now, is acute kidney injury. Early on, there may have been concerns that these drugs might dehydrate one a little bit, and so may actually put one at risk of acute kidney injury, when it turns out the exact opposite appears to be the case. And there's really clear evidence from the heart failure trials and from chronic kidney disease that these drugs are protecting patients from acute kidney injury. So overall, there's a lot of really supportive data for this whole class of drugs in these high-risk patients. I think there's a whole separate question to ask about what about patients with type 2 diabetes who don't have those conditions? And that is one that we could, debate, and which I think we need to tackle. What we really need to do is to try and prevent patients from getting to the level of having heart failure, having chronic kidney disease, and that everybody is, trying to think how best to tackle that question, one of the biggest questions.
Yeah, absolutely. Maybe some exciting trials on the horizon for prevention with these medicines that we already know are really great in the high risk patients we've been talking about. So usually at this point, I would ask something about will this be practice changing? Obviously it's well recognized how important this class of medications is for many different things. From a cardiology standpoint, heart failure, oftentimes we'll be starting these medicines in the hospital. Do you think this trial has the potential to change kind of the GFR cutoff that folks are comfortable with prescribing these medications, since you did enroll a lot of people with lower GFRs than the previous studies?
Yes, I mean, the results appear very consistent across different groups by EGFR. And while the results we've talked about have kind of been fairly, you count numbers of events based on patients crossing a certain threshold, there's a number of other analyses that we are doing and which other people have already done for other trials, which is to look not just at did they cut a certain threshold, but what happened to the trajectory of the EGFR over time. Did it slow down the worsening on average? And what you see in other trials is certainly that these drugs seem to slow down the worsening of EGFR over time. And indeed, in the EMPA-Kidney trial, you see exactly the same. And so we think there's very convincing evidence at patients at all levels of EGFR that have been studied that these drugs are going to be protective. I hope that we can also generate some data even in patients with an EGFR below 20. And I know my kidney colleagues, Will Harrington and Richard Haynes, who led the trial, are having a close look at that because other trials probably don't have too many patients. So there's a lot of evidence, I think, to back up using these drugs early on. And so, yeah, very much hope that that will happen. I think, as I alluded to earlier, if I was thinking of a few places where we could do with better evidence, the one that I would love to see more research into is in patients with type 1 diabetes. Often these patients have got disease for decades and are at higher risk of complications than patients with type 2 diabetes. And there's been this concern around ketoacidosis, and so people have been somewhat cautious around testing these drugs in patients with type 1 diabetes. We ourselves recruited a small number of type 1 diabetes for a short period early on in the trial, and there were indeed various other trials conducted only in patients with type 1 diabetes, and those have kind of come to a halt. Yet these drugs could be very useful in patients with type 1 diabetes if we can just find a way to balance this potential risk of ketoacidosis and potentially substantial benefits. So if I was looking for other populations to study, because I think we've already established the benefit in everybody else that's been studied, I would say type 1 patients with type 1 diabetes would be top of my list.
Absolutely. Yeah, that's exciting to hear about. I'm med peds and I see lots of folks with type 1 diabetes that could certainly benefit. And how cool would it be to just prevent them from ever developing cardiovascular kidney disease? Kind of back, I just want to make sure, Dr. Preiss, have we gone through everything in this amazing trial you're presenting that you want to talk about? Because I don't want to skip over anything you wanted to bring up.
I think one final thing we probably haven't, I think one thing I need to do is firstly recognize contributions of multiple people to this trial, and also to remark on the impact of COVID on the trial. So COVID itself struck in the middle of recruitment to this trial. Obviously that was unknown, unplanned, and my colleagues who were running the trial, the engine room of the trial, really pulled out all the stops, and that counts for all the sites around these 8 countries, all the regional academic units, and my colleagues here in Oxford running the trial. They had to come up with multiple solutions to very challenging circumstances. Unfortunately, many research studies stopped during the COVID pandemic for obvious reasons, but they managed to keep this trial ongoing. They managed to keep the number of patients on treatment fantastically high by, for example, couriering drug out to their homes, managed to keep very high numbers getting blood samples taken. And bad as the pandemic was, what we managed to do was, as the pandemic kind of swept across the world, is that we almost had enough geographic coverage across these 8 countries to have some countries recruiting well, while others had to almost close down for a period of time when COVID was very active there. So it was a trial run under some of the most challenging circumstances, I think, that one could imagine, none of which was foreseen at the start. But I think if you look at the quality in terms of just how many patients stayed on drug, how many had blood samples taken, because obviously in a trial like this, blood sampling was of fundamental importance. It's truly remarkable what these other people managed. So for me, having seen what the team achieved And again, to highlight Will Harrington and Richard Haynes, who ran the trial, and everybody else who wouldn't have time to comment on their contributions, and their running of the trial was really notable. And I'm sure they would always also want me to highlight, in particular, the participants that put themselves forwards, and indeed in the midst of COVID were willing to keep contributing to the trial when it would be very easy to just stop or pull out. So I think we're grateful to everybody's contribution, and in particular the participants.
Yeah, that is an incredible thing to note, that the logistics for a trial like this are immense without a worldwide pandemic and different countries with different responses and all of that. So thank you for bringing that up. That's amazing to reflect on. This has been great. Thank you so much for taking the time to talk through all of this. I've learned a lot, and I'm really excited by these results that you were able to share with us today. Anything else we kind of talked about, like, areas that there could be more research? Anything else that we should keep our eyes open for in the future related to this trial that you shared today?
Yes, this trial continues to follow patients up in many parts of the world. So my colleagues are running an extension to the trial of observational follow-up. So we know what happens over 2 years. What we don't know is quite what happens beyond that. So the majority of EMPA-Kidney patients are taking part in a 2-year extension where we will be tracking their health with regards to important outcomes, and indeed what happens to their kidney function. So they won't be getting randomized treatment anymore, but they will be having these assessments performed by the staff at the sites. Will continue to follow them up based on available records. And I think those results, will take a couple of years to emerge, but it will be fascinating to see what happens, after a period of treatment, to see how much of this remarkable kidney disease benefit in particular is maintained. Maybe the benefit continues to accrue. Maybe it tapers off. We really don't know. And so I think this trial will be able to establish that. The other patients to study type 1 diabetes, as I've said, would be top of my wish list for investigators in that area to do. And beyond that, I think one of the huge areas to tackle, but a very difficult one, is how really to treat patients with type 2 diabetes before they run into these kind of complications, so we can actually prevent them from happening in the first place. So those would be on my wish list.
Fascinating. Spoken like a true preventative cardiologist. all really interesting. Are with the follow-up for this trial, are you guys going to follow up cardiovascular hospitalizations with that as well?
Yes, cardiovascular outcomes, kidney function, and any reasons for dying are going to be the outcomes of particular interest in the 2-year in the 2-year follow-up that's ongoing at the moment.
Okay, fascinating. Really interesting and exciting stuff. I have kind of reached the end of the questions that were on my mind reading through this, so I don't think I have too much more to ask. But again, thank you so much for your time. This has been super interesting, and I think will be really exciting for everyone at AHA and all cardiologists and nephrologists in general. So,
well, thank you for the opportunity to speak to you, and we look forward to hopefully these medications being used in appropriate people around the world. So I appreciate the opportunity.